smoking, and he is diabetic, and he has a hemoglobin H1C about 9, but he wants to have teeth. And you see how nicely has a very good oral hygiene. Doesn't need to go to the hygienist. Takes good care of his teeth. Good guy. And if you open, you will see different kind of prosthetic work in his mouth. Some are implants, some are teeth. You can see here periodontal disease around his teeth. And this is the panoramic X-ray of this guy. So tell me, if he comes to you, he's a smoker, he has H1C of 9, what do you do with him? You make him implants, you do immediate loading, you do immediate implantation. What do you think? Tell him to go away. Hand him to your best friend. Well, first of all, we asked him to try and reduce smoking and to try and balance his diabetes. Once he stopped smoking and he managed to get A1C of less than 7, we decided to try and treat him. But you can see that there are many problems. Are you going to leave these implants? Are you going to remove all those implants? What do you think? What are you going to do with the temporary? What kind of temporary will you do? Will you do something fixed? Will you do something removable? Any suggestions? Okay. So, this is his status, as you can see. This is his CT. You see that we are missing bone on both sinuses. You can see bone resorption. You can see bifurcation. You can see missing bone in the lower jaw. But if you look carefully, you can see that those 3 implants are okay. So one of the problems is if you try to remove them, you're going to lose a lot of bone. So you need to decide whether you're going to remove those implants or not, or what else are you going to do with them. And you need to decide what would be the temporary in this case. So if we take a careful look, this is the right maxillary sextant. We don't have to make a lot of decisions here. This is the middle maxillary sextant. I don't know if we can leave here anything. Even if we try to think about terminal approach, to do transitional, something temporary, it will be difficult. And again, some more problematic implants. This implant is basically very close to the sinus, and we probably have a no-answer communication when we take it out. We go to the lower jaw. Well, basically those 2 implants, maybe they can support some interim prosthesis. This implant has too much bone loss and periimplantitis, so we probably need to remove it. Here, I don't think we can do much, but those implants seem okay. I mean, we have some bone loss, but not too much. So maybe we can also use them. And again, maybe we can use those tools for something interim but of course not for something which is permanent. So, first we took out everything from the upper jaw. You can see that this implant already came out when we took out the bridge. Other parts came out. So we wanted to see what we can do temporarily on the side. On the lower jaw, again, we removed the prosthetics, trying to see what is left out of it. And we wanted to do as much as possible fixed restoration during the temporary time. So you can see here we're planning a fixed bridge with some removable partial denture, but we don't know what will be the prognosis of it because we don't really have too many abutments in the jaw. So we take out everything. We can place here the temporary bridge in the upper jaw and lower jaw, and then we can put the removable partial denture in the upper jaw. So actually, this is how we started, and this is where we are now. Well, it is much better. At least this oral hygiene improved. At least now we can see some gingiva, some healthy gingiva. And we do reevaluation. So basically, this is what we are left in every jaw and the temporary restoration. And also we improve the occlusion. And basically, this is the treatment plan. We plan to do sinus augmentation on both sides. We plan to do bone augmentation in the anterior maxilla, and we plan to place implants in both upper and lower jaw. But in the anterior area, because those implants were quite stable and we didn't want to lose bone, we decided to leave those two implants, and this implant, not to remove it, but just to cut it, to leave it as a slipper, to allow better oral hygiene. Because you can see that there is too much proximity between those implants, and this proximity will not enable good oral hygiene afterwards. So, we need to take out implants 12 and 13. Now, removal of an implant is not always very easy. We try to do it with removal tool. We try to do it with different tools that we can place inside and do reverse torque. But not always it is doable. So many times we have to remove bone around the implant in order to move it, take it out, and then of course we need to do bone grafting in this area. So we remove both implants. You can see here the defects that we have. We continue in the same meeting to do sinus augmentation, open the sinus, and fill the sinus, and also did ridge augmentation, covered everything with membrane, and did primary closure. Now we continue to the other side. Now we're going to remove 21, 24, 25, and we want to try and preserve some of 27 in order to have some fixed support. But again, it's very problematic, so we told the patients that we won't try and keep it but we cannot guarantee that it will last till the end of the restoration. So again, we take out the implants, soft tissue growing there was removed. We take out the mesobuccal root, and again, we do sinus augmentation and alveolar rejuvenation, membrane coverage, and closure. So you see already how much effort we do and how many stages we have to do in order to cope with this failure test. Failure cases are much more complex and much more challenging than regular cases. Well, during the follow-up, we have some soft tissue dehiscence. You can see it over here. But as I said before, we do not touch it. We just leave it, keep it clean, and slowly soft tissue will grow up there. And you can see that soft tissue eventually healed. And you can see also that the number of abutments that we have in the upper jaw is not so good. So, unfortunately, we had too much mobility of those teeth, so we had to remove them, and we had to go to full upper denture. So again, you need what happens that we have too much skin in the submental area. So this skin can be used for vertical augmentation. And if you use the skin, you will gain twice. First, you'll have enough soft tissue for the vertical augmentation. Second, for the patient, it will look like a chin lift. Suddenly the patient will look much younger. So, the concept of Marx was, instead of going intraorally, let's go extraorally with the submental approach. And then you can open the flap bilaterally to the border of the masseter. Now, the Marx approach was to place the implants at this stage, to use the implants for space maintenance, then go to the posterior iliac crest, take from the posterior iliac crest 60 cc of autogenous bone, to place this autogenous bone around the implants, and get a very nice result. The problem was that because the implants were placed by this submental approach, it was almost impossible to place them in a correct position vertically. So many of those implants could not be used, and it was not possible to do fixed implant supported. You could do only removable denture over it. But again, it was a very good solution. You see, the patient goes from this to this. It is an amazing solution. And another drawback is to take posterior iliac crest bone. How many patients agree to take bones from the posterior iliac? And if you did the operation, you know that to take bone from the posterior iliac is not simple. You have to turn the patient. You have to keep the tubus. You have to turn the patient back. It's taking you a lot of time. The approach in the posterior iliac is not problematic, but all the changing the patient from one position to the second position is not really easy, and it is not an everyday procedure. So we wanted to simplify this procedure. So again, we used the allograft blocks, we used O6 plus, and we used recombinant BMP2. This way, we didn't have to get any bone from anywhere. We had all the bone in boxes. Another advantage was minimal resorption. The consolidation was 4 to 6 months. Implants were placed at second stage in an intraoral access. And let me show you how we did. We published the first cases in an Israeli journal, and I'll show you the last publication in iJournal. So let's go through some cases. Those cases, in most of the time, are implant failures, because implants are done when the mandible is over 10 millimeters, but due to the resorption and peri-implant disease, you have a lot of bone resorption. So in this case, we took out the implants, and you can see how the mandible looks after we took out the implants. So we do a segmental approach. You can see here that we always manage to isolate the mental nerve. Here you can see the genioglossus muscle. And all this is done extraorally. The oral cavity is here. This is segmental. Okay, don't forget. This is not intraoral. This is segmental. Oral is over here. And we use blow grafts, we fix them, we cover them with particles, O6 and recombinant BMP2, and we close it. You see that the approach is segmental. The advantage of this approach that intraorally the soft tissue is completely intact. If you want to do an intraoral incision and try to gain so much soft tissue in the anterior mandible, it is not possible, because the lean one is attached to the genial tubercles. So you cannot release the genioglossus or the geniohyoid. So the only way to gain this soft tissue is by using the extraoral soft tissue that will be test superiorly. And here you can see the block fixation. And look how nicely we have now new bone in the anterior mandible. Now we can place 4 to 6 implants and do either fixed or a fixed removable. Another case, patient with osteopenia. Look at the mandible. You know, sometimes I present those cases and somebody says, I can place here 2 implants of 4 millimeters from stroma. I said, okay, do it. You know, to place here 2 implants 4 millimeters of stroma, it's a nice idea. I'm not sure it's practical. And I'm not sure that the mandible will remain afterwards. So, again, you can see nothing, no mandible almost. So again, we use the segmental approach, and we cover it, particles, membrane, recombinant BMP2, and again we close it. So you can see already the patient was very happy, because suddenly the chin looks very nice. It's like a chin lift. She doesn't need a plastic surgeon anymore. And this is the post-op panoramic view. This is a newborn formation. And in this case, we placed 4 implants. And look how nicely it looks. The scar is minimal. Look at the profile. Profile now is much better. Completely different from what we started. And this is how it looks after 12 years. This patient, she's in love with me. And she comes every year with her panoramic radiograph. So this is 12-year follow-up on the case. And it really looks very, very nice. I'm very satisfied. And she comes, I tell her everything's okay. She goes with the hygienist and she keeps it in place. And why? Because this lady, before the treatment, she was really despaired. She didn't know what to do. Nobody wanted to treat her. She couldn't wear a denture. She looked terrible. So by this solution, which is relatively simple, it's not very simple, but it's relatively simple, now she's living for 12 years and everything is perfect. And this is our intraoral view. This is a funny case. This patient, she had, unfortunately, Alzheimer's. So as you see here, again, as I told you, most of the cases are implant failures. She came with this picture, and then we did the same procedure, and we placed 4 implants. And then she disappeared. After 2 years, she comes back. She says, "Doctor, when are you going to place these implants?" I said, "What do you mean? I already placed the implants." "No, you didn't place the implants." "But look, this is the X-ray, place the implant." "No, you didn't place the implant." And at that moment, her husband says to me, "Doctor, I want to speak to you." I said, "Okay." So I go aside and said, "Look, I know that you placed the implant, but don't be mad. She has Alzheimer's. She doesn't remember. We had some problems. So we went to some doctor and didn't know what to do. So he removed all the implants." I said, "What removed all the implants?" "We worked like crazy to build this bone and he removed the implants." I said, "What can I do? Doctor, please, can you help us?" Well, so eventually they had to pay again because I didn't agree to do it without them paying because I was so mad that somebody took those implants. So they paid again, and eventually we did 6 implants, and she got a fixed restoration, and she was happy. So you know, sometimes crazy things happen. And another example, again, fixed from 5 implants. And I think this will be the last case for now. Again, less than 10 millimeter high. You can see here this mandible, and this was a very young lady. She was about 40 years old. But she lost her teeth very early in her life. And you can see here what a big mandible she had. Now she went to a colleague of mine, an oral maxillofacial surgeon, and she suggested her that she will take the genial tubercles and she will do bone graft with the genial tubercle. I said it's a very nice idea, but I don't think we're going to do this idea. So, again, we decided to do the submental approach. You can see here the bone towards the genial muscles. And again, to take it as a bone graft, I don't think it's a good idea. Again, we placed the blocks. You can see here more than 10 millimeters vertical augmentation, covered with osteoclast and the combinant B2. We placed more bone in the direction of the masseter. We also did here lateralization of the nerve because we wanted to gain more space, and by the submental approach to move the nerve, it's relatively and not very difficult. And we covered it. and you can see nothing happened intraorally. So relative to the mandible, the maxilla was very easy. We had Coward and Howell +4, which is okay. So we had knife ridge anteriorly and basically nothing posteriorly, but relative to the mandible it was easy. So we did blow grafting again in the anterior maxilla, covered it with particles, recombinant BMP2, O6+, as you see here, closed everything. We also did subnasal elevation and sinus augmentation. And you can see here the screws, but again, we had enough bone. And you can see here the bone, that you can see here the lateralization of the nerve. And look here how close we were to the inferior border of the mandible. And we took everything out. And look at the chin. And look how nicely the new bone were generated. So we placed implants in maxilla and in the mandible. This is how she started and this is how she ended. And after she finished the treatment, you think she was happy? No, she's Jewish. She cannot be happy. She said, why I don't have a second molar on this part? The cheek is coming down. It doesn't look nice. I said, Lady, go somewhere else, go. Okay? But she's okay. She's coming every year for follow-up, and eventually she understood she exaggerated a little bit, and she's happy. So, we published this in IJOMI 2021, 16 cases, less than 10 millimeter, the cytology O6 recombinant BMP, took all those parameters, took measurements before and after. You can see this table. In general, we waited between 4 to 6 months. Most of the cases were, as you see here, most of the cases were implant failure. And we took those measurements, midline and 15 millimeters from midline, to understand how much bone we gained. And actually we gained a lot of bone. We gained 10.7 millimeters of bone height. I'm not aware of any article that describes this amount of bone gain height with allogenic bone. So this is really the highest bone gain with allogenic bone ever described. And the reason for that is the extraoral approach, which allows you enough soft tissue. And it demonstrates to you that when you ask what is the limit of vertical augmentation, there's actually no limit for vertical augmentation. The limit for vertical augmentation is how much soft tissue release you can achieve. If you achieve enough soft tissue release, you will gain vertical augmentation. The secret of vertical augmentation is soft tissue release. If you do enough, you get bone. If you don't do enough, you will not get bone. So, we placed 73 implants. We had 4 early failures, 2 late failures, and a CSR of 92%, which is very nice. So the submental approach is predictable. The biomaterials are a good alternative to autogenous bone. O6+, a combination of O6+ and BMP2 provide predictable angiogenesis. The blocks give you space maintenance. The fixation screws are nice. Implants are good. Most of the implants here were MIS implants. And this is my staff. This is my wife. She's a periodontist. Nobody's perfect. And this is Professor Insal. He's a prosthodontist. He's working with prosthetics. And those are members of my surgical department. And Dr. Asafrana, he is another prosthodontist that is working with me. Okay, so thank you very much. And if you have questions, I'd be happy to answer.
Quý bác sĩ có câu hỏi nào đặt ra không ạ? Xin nếu là có câu hỏi xin chúng ta giơ tay lên để thực hiện micro. Dạ, có vẻ là cái ghép xương đây là xử lý ca thất bại dễ phải không ạ? Không thấy câu hỏi nào cả. Dạ, giờ này thì chúng ta sẽ nghỉ trưa và ăn trưa.